sure you guys are all aware of the basic structure of the exam with it coming up so soon, but I just thought it's always worth kind of just mentioning this as we start. So I took this from the RCR curriculum. So essentially, you need to know the knowledge of anatomy that underpins all radiological imaging, including the following, modalities: so radiography, fluoroscopy, angiography, CT, ultrasound, and MRI. And that's what I've tried to include today, and Bhavna's tried to include as well. Is there's lots of images of different anatomical structures that may be quite straightforward, but just how they look in different modalities. So, as I'm sure you're aware, of the way that the exam's structured, so 100 questions. Most of the questions are an arrow pointing to the structure and saying name the arrowed structure, but try not to get caught out, because there will be questions where they try and trip you up and ask you, something other than that you may not be expecting. So always, again, I'm sure you're all aware, but always reread the question. And as we know, kind of accurate spelling is expected, and be careful of your lefts and rights. So making sure that you put those correctly when you can. So that's the basics. In terms of the aims of my part of the presentation, again, this is from the RCR anatomy guidance. I'm going to go at the very start. I'm going to go through the perirenal and pararenal spaces and fascia, as to kick it all off, and then I'm going to work my way through the genitourinary tract, starting at the kidneys and bladder, and working my way down to the testes and epididymis. Bhavna's going to mention the peritoneal reflections and spaces as well in her talk, so we'll cover all of this really. And as I said, in terms of the way that I'm going to do it, it's going to each time going through a general overview of the anatomy through diagrams, and then trying to include as many different modalities as I can that show these structures. I'll mention some common variants that we'll see that are relevant for the exam, and then at the very end of both of our talks, we'll do a quiz to test your knowledge at the end. Kind of halfway through, me and Bhavna will switch over, and that'll give a period of time for a bit of a break and a Q&A. If there are any questions, pop them in the chat. I will try to answer them as I go along. But if I'm not able to do that, or I miss any, then we'll pick those up at the end of the first section. So, as I mentioned, firstly, I'm going to go through, as the curriculum states, talking about the retroperitoneum and the retroperitoneal spaces. So this is quite a good diagram, where, as we can see at the front, this is where the peritoneum should be. So posterior to that, this is all the retroperitoneum. And it's important for us to know the way that this is divided into 3 different spaces and how it's divided. So this is by fascial plane. So at the very kind of anterior border, we have the parietal peritoneum. Posterior part of that runs along the front here, and the anterior renal fascia, and posteriorly, and the parietal peritoneum anteriorly, then form the anterior pararenal space, which contains the ascending colon, duodenum, the pancreas, and descending colon. And then as we move further posteriorly, the section that's probably most important for us clinically is to know the perirenal space. So the perirenal space that contains the kidneys and the adrenal glands. And anteriorly, we have the anterior renal fascia, which runs across here, which is also known as Gerota's fascia. And then posteriorly, we have the posterior renal fascia, which is also known as Zucker-Campbell fascia. And that forms, as we said, the perirenal space. And then posteriorly, we have the posterior pararenal space, which is anteriorly bordered by the posterior renal fascia, and then posteriorly bordered by the transversalis fascia. There's nothing really very exciting in this area, but those are the 3 retroperitoneal spaces to be aware of: anterior pararenal space, perirenal space, and the posterior pararenal space. This is just another way that I've shown it using a kind of a slice through an axial CT. So you can actually see the um, anterior renal fascia on CT. It's thinner than the posterior fascia because it's only one fascial plane. And this is, as I said, just to reiterate, this is Schirotter's fascia, anterior renal fascia, Schirotter's fascia. And then posteriorly, as we can see on this schematic, it forms two layers. Here, where it kind of merges with the lateral conal fascia, so it appears slightly thicker on CT. And here we can see the lateral conal fascia coming in, and signified by the yellow arrow, that is Zucker-Kandel's fascia, posterior renal fascia. So this area, this area here, this fatty tissue, is the containing the kidney and the adrenal glands, is the perirenal space. So moving on to the kidneys. So as I'm sure you're all aware, the kidneys, they lie approximately at the level between T12 and L3. The right side lies usually lower, secondary to its boundary with the liver. And the way that they run is they run parallel to the psoas at an oblique angle. And then kind of on this schematic diagram, we can go kind of posteriorly, kind of laterally, and work our way in. You've got a kind of a renal capsule that surrounds the kidney kind of laterally. And as you come in, you move into the cortex here, cortex surrounding it, which is containing the arcuate vessels, which we will speak a bit more about. And then these extensions of the cortex that kind of run through the middle, that border the medulla of the kidneys. These are called Berthin's columns, and these are kind of extensions of the cortex, and we will look at those on further imaging kind of as we work our way through. And as we said here, these kind of triangular structures, these are the medulla of the kidneys. And then kind of most medially, we get the collecting system, which extends from the minor calyces that then drain into the major calyces, which then drain into the renal pelvis, and then kind of, as we know, out of the kidney into the ureter. And we will speak about the ureter some more when we come on to it. So arterial supply, again, just a schematic diagram. We'll come on to the images in a second. So as we know, the arterial, in a normal anatomy, the arterial supply is the right and left renal arteries, so paired arteries, which are the first paired major vessels to arise from the abdominal aorta, typically arising at the level of L1, L2 intervertebral disc and below the level of the SMA. So in terms of how we, other pointers that might make us think which is the right and which is the left renal artery, is that the right is the course that they take. So the right renal artery takes a more kind of inferior and oblique course, and runs posterior to the inferior vena cava and the renal vein, whereas the left renal artery is a shorter course and runs kind of more horizontally, as we'll see on the imaging when we come to it. But again, the arterial supply runs posterior to the renal vein, so these can be quite helpful pointers if you get some imaging to be able to determine between the renal vessels. So kind of coming to the imaging, I've included a renal angiogram. So this is so kind of running through this. This is the catheter running into the left main renal artery. The artery itself does split into anterior and posterior divisions. On the practice questions that I did last year, and certainly in the exam, it wasn't something that we were tested on. But I think it would be difficult for you to be expected to name the anterior or the posterior divisions of the renal artery. But I think certainly this is fair game when we start getting into the where the renal artery becomes segmental branches. and then certainly when they become interlobar branches that run adjacent to the medulla, the medullary pyramids. And then, as we can see, kind of in the cortex, these smaller vessels are the arcuate vessels that they eventually branch into. So, main renal artery, anterior and posterior divisions, segmental vessels, interlobar vessels, and then arcuate vessels finally. And then certainly on some of the practice questions I saw last year, there were some Doppler images from kidney ultrasound. So, I mean, generally, if the vessels that you're going to see that are running adjacent to the medulla are going to be the interlobar vessels. Vessels that you see peripherally, kind of more towards the cortex, are going to be the arcuate vessels. And then obviously anything before that, more kind of around the hilar area, are going to be segmental branches. So this is a coronal CTA. The red arrows show the renal arteries. So as we can see, this is the right side. We can see the inferior vena cava running through the liver, the caudate lobe of the liver. We can see the liver here, so we know that this is the right side anyway. And as we spoke about, you can see kind of from the way that this vessel runs, it takes more of an oblique angle and runs inferiorly, whereas the left renal artery, you can see even just from this slice that it has more of a kind of horizontal appearance. So venous drainage. So again, paired vessels, left and right renal veins. As we said previously, the renal veins run anteriorly to the renal arteries, and they drain into the inferior vena cava. And kind of opposite to what we mentioned before, and it makes sense, is that the right renal vein is shorter than the left renal vein. It's got a shorter course to take to reach the IVC. The left renal vein is much longer, as this needs to course kind of normally in normal anatomy anteriorly to the aorta, into the draining into the IVC. What I've mentioned here, and we'll have some images of as we go through, which I think was important, is the left gonadal vein. So the left ovarian vein, or the left testicular vein. Left testicular vein, obviously, in men, and left ovarian vein in women. Because this was something that seemed to come up quite a bit in practice questions that I did, the drainage of the left gonadal vein from the pelvis into the left renal vein, and then into the inferior vena cava, but we'll have some images of that as well as we go through. So I've just included an axial CT here. So as we can see here, this is the inferior vena cava on the right side, and then this is the course of the renal vein. You can see most of its course kind of running anteriorly to in normal anatomy, to the abdominal aorta, draining into the inferior vena cava. And then this is another slice to kind of show a few more structures that you might see in a single slice on an axial CT image. So again, you can see more to the left side and smaller in caliber, the abdominal aorta, the inferior vena cava, and then you can see that the right renal vein courses anteriorly and has a larger caliber than the right renal artery, and as we mentioned before, has a short course to drain into the inferior vena cava. As we mentioned, so just including an image here to show. We've got a few more images, and Bhavna goes into it a little bit as well. So I remember seeing in practice questions kind of some images that would show a vessel running, a kind of relatively large caliber vessel running from the pelvis, draining into a relatively large caliber renal vessel. So that that's to be aware of in terms of left gonadal vein. And obviously, if you can see, evidence that the patient is female, then you can call it the left ovarian vein. If you can see evidence that the patient is male, you can call it the left testicular vein, or you can call it the left gonadal vein if there's nothing from the imaging to make you aware that that's the case. So I've included a plain film here because you can see, as highlighted on here, you can see the outline of the kidneys. The left one you can't see as clearly because it's obscured by bile gas, but certainly on the right side, as highlighted, you can see the outline of the right kidney. And just out of interest, on this particular plain film, you can see another anatomical variant. So this is Riedel's lobe of the liver, which is kind of an extended extension of the right lobe of the liver that kind of runs further than it should down into the pelvis, and has this kind of rounded appearance at the end. So I'm not sure how well this projects, but this is some ultrasound images of the kidney. So in long section, we can see the cortex surrounding the most laterally, and the cortex of the kidney is in normal anatomy and without pathology has decreased echogenicity when compared to the liver. Even more reduced echogenicity is the medullary pyramids, which are quite easily noticeable. They're very echogenic, and they've got a distinctive kind of shape that we can see on other imaging as well. These echogenic areas here, something that seems to come up on questions quite a bit, practice questions. This is renal sinus fat. So on an ultrasound, if you see that on a slice and it's pointing to this very echogenic material, then this is renal sinus fat on there. So again, showing the cortex, medulla, and the renal sinus. And then this is just a transverse section of the kidney in ultrasound, again showing a renal capsule, which is the most peripheral part coming into the cortex, and again showing this echogenic renal sinus fat. So coronal CT, portal venous CT, again just showing the main parts of the kidney. So we can see this on this, in this particular phase of imaging, the cortex is hyper attenuating when compared to the rest of the kidney. And this is where the renal columns, the columns of Burton, you can be made aware, because these are, as you can see, these areas that look like normal cortex that run between the cortex towards the hilum, in between the renal medulla. So these are the renal columns of Burton. That's certainly something to remember. And then, as we can see as well, you can label the superior poles and the inferior poles of the kidneys. And as you come into the centre here, you can start to see the renal pelvis form there. And we've got some urographic images later, which will demonstrate the renal pelvis a bit clearer, and the PUJ. So moving on to the adrenal glands, so they sit above the kidneys, which is why they also have the other name suprarenal glands. They generally sit anteromedially to the kidneys, and they're asymmetrical in their appearance. In terms of arterial supply, this isn't something that you're generally going to be able to see on imaging, but it's obviously for the anatomy, it's worth knowing the kind of the superior renal artery, the superior portion is supplied by the inferior phrenic artery. The biggest section is the middle section, which is supplied by the abdominal aorta directly. So we can see here on the schematic, and then the inferior portion is supplied by the renal artery. And in terms of venous supply, so just two draining veins, so three arteries supplying and just two veins draining. So on the left side, the left adrenal vein drains into the left renal vein. On the right side, it drains directly into the inferior vena cava. So and also to mention on coronal imaging, that's when you can kind of see the main difference in morphology of the adrenal glands, because the right adrenal gland appears more pyramidal in structure, and the left appears more crescenteric in shape. So that can be helpful in terms of differentiating, but obviously not, the crux of how you would. So this is just on coronal CT, just on one slice you can see on this side we can see the right adrenal gland kind of nestled in between, next to the right lobe of the liver and the inferior vena cava. And you can see some kidney parenchyma coming into view here. And then on the left side again we can see the adrenal gland here with its kind of classic shape with the medial and lateral limbs, which is, you can see, adjacent to the spleen here. So in terms of variants in terms of the kidney, there's so many variants, but I've just included ones that I think more likely to be tested and that you're more likely to need to know. So first one is the horseshoe kidney, which I'm sure you've all heard of before. So this is a fusion in the midline of two kidneys which are functioning. At the point where they connect, so on this CT here, at the point at which they connect, so this area here is called the isthmus. 90% of them are fused at the lower poles, and the ascent of the kidney is restricted by the inferior mesenteric artery. And we have got some more imaging of the horseshoe kidney later. Pelvic kidney. So this is a kidney which is, as it says, within the pelvis and hasn't completed its ascent. So it's fixed. And as we can see on here, you can see the morphology of what appears to be a normal kidney, just lower in the pelvis, adjacent to kind of the as you can see, the SI joint and the pelvic bones. So that's quite an easy one to be aware of. Dromedary hump. This is something I've included because it's something that we do see a lot in practice as well, and may sometimes trick people into thinking it's pathology. So on the left kidney, if you see this kind of smooth bulge on the lateral aspect of the left kidney, this is actually a normal variant, and it's caused by the impression of the spleen. So this is something to be aware of as a normal variant of the kidney. And then in terms of renal vasculature, so as we can see, commonly you can get accessory renal arteries. So as we can see on this MRA, we've got two renal arteries on the right side, and then kind of three renal arteries on the left side. So this is an MRA of the renal vessels. So that's quite a common variant to be aware of. This is another really important one that's testable and is applicable and is relevant for clinical practice as well. So as we spoke about before, the left renal vein in normal anatomy courses anteriorly to the abdominal aorta, drains into the IVC. But in a retro-aortic left renal vein, as it says on the tin, the left renal vein courses posteriorly to the abdominal aorta and drains into the inferior vena cava. And this is an important thing for clinical practice because patients who are having retroperitoneal surgery or AAA repairs acutely, it's important to let the surgeons and the endovascular team know about this anatomical variant to prevent kind of injury during the procedure. So moving on to the ureters, again, as we know, paired structures can be split generally into kind of three parts. So the abdominal part, which is the largest part, is the area that runs from the renal pelvis itself down into the pelvis, and then at the pelvic brim then becomes the pelvic part of the ureter. And then when it actually reaches the bladder and it's within the bladder wall, there's the intravesical portion of the ureter. Just for kind of clinical relevance, there's three different points within the ureter where you might see pathology in terms of stones getting stuck, and that's where the ureter kind of constricts down naturally. And so in this part, the first part is at the kind of pelvic ureteric junction. Those are the kind of places to kind of look for stones when you're looking at your CT-KUBs on core. And then at the pelvic inlet, there's a constriction caused when it kind of courses via the iliac vessels. And then as the ureter enters the bladder posteriorly at the vesico-ureteric junction. So that's the ureter's bilateral structures, three parts with three different kind of separate areas of natural constriction where you might see pathology. This is just a schematic diagram that I've included to show where the ureters enter the bladder. So they enter kind of posteriorly, and they enter posteriorly here. And as you can see, this is the abdominal part of the ureter, and then when it reaches the pelvic brim, it becomes the pelvic part, and then of course is where it enters the bladder posteriorly at the VUJ. That's where you get the intramural part of the ureter, and we'll talk about bladder anatomy as when we come to it. So IV urograms, these are outdated really in terms of now using kind of CT urograms in clinical practice, but it does highlight the anatomy quite well. So it's useful to know, and it's useful for you to be able to get a feel for these different parts. So as we can see highlighted by the red arrows, you can see the left renal pelvis. You can even kind of in these areas, you can see the minor calyces draining into the major calyces, and then the renal pelvis. And then when you see this kind of first kind of constriction, where the renal pelvis kind of courses into the left ureter, that's the pelvic ureteric junction, and that's one of those areas of constriction that I spoke about before. And then as you follow it down, I think you can see kind of in this area at near the pelvic brim, you can see another constriction there. So it's really at that point that it then becomes the pelvic part of the ureter. And then where it enters the bladder posteriorly is the vesico-ureteric junction. Here labelled with the red arrow is the right vesico-ureteric junction. And as we'd expect to see at the bottom, you can see contrast filling within the bladder. This is just basically the same image, but via a CT urogram, which just is another, just to kind of get your eye in terms of the different modalities for the different parts of the anatomy. And again here, you can see on this coronal image the renal pelvis on the left side becoming the ureter at the pelvic ureteric junction, and then coursing down to drain into the bladder posteriorly. And then we can see the bladder here filled with contrast. So in terms of the collecting system, so kind of variant anatomy is important to know. So as we know, as we already know, quite straightforward that in a normal system you have just two kind of pelvic haloceal systems that drain into one ureter that then drains into the bladder posteriorly. In a duplex system, it's kind of getting your head around the nomenclature really. So by kind of duplex kidney, it essentially means that there's two pelvic haloceal collecting systems from one kidney. But they can either drain into they can so as shown on this IVU on the left side, that you've got a duplex kidney here, so two systems, two separate systems, but these can either drain into a single ureter, as we can see, just one single ureter draining down into the bladder, or you can get a duplex system that drains into that becomes two ureters that then merge and become one ureter further down and drain into the bladder, and that's called a bifid ureter. And then obviously we can't see the whole course of this on this axial CT, but you can see there are two ureters, um, that can be seen on the right side. Um, so this is a true kind of full duplicated ureter. So what you would see is two collecting systems draining into two distinct ureters that then drain into the bladder at two separate points. So yeah, moving on to the bladder now. So really not much really to say about the bladder, and I think it's shown in some of the MR imaging that Bhavna is going to show you in the next part of the talk. So essentially, in terms of its shape, it's a triangular shape. We can't really see it on this. Can't really. You'll see from the images that we'll talk through it further, but the posterior base of the bladder is fixed in the retroperitoneum. Well, it's extraperitoneal, and it's called the fundus. And then the superior part of the bladder is what we call the dome. And then the kind of anterior part that you'll see in the next couple of images is called the apex of the bladder. And this area at the back is an area of mucosal tissue, triangular mucosal tissue called the trigone. And this is again trigone, triangular, and this is made up by two separate openings of the ureter, so the vesico-ureteric junctions draining into the bladder, and then at the kind of tip of the trigone inferiorly, it becomes the urethral orifice. So I've included here a micturating cystourethrogram. So in this study, it's quite a common study done in the pediatric population, and what happens is the patient's catheterized under fluoroscopic guidance. They have their bladder filled with contrast, as you can see here. This is the bladder filled with contrast on the AP image. And then when this has happened, they have the catheter removed, and then fluoroscopic images are taken of them voiding, and that can not only show the bladder, but it can also show the urethra as well. And we'll talk through the urethra a bit more in the next section. So ultrasound, this is what the bladder looks like on ultrasound. So on transverse view, you can see this is a well-filled bladder, and the bladder has this kind of hyperechogenic. Normal bladder has this kind of smooth hyperechogenic outline, and this is a sagittal view. This is a sagittal view through the bladder. And the next slide, it makes it a little bit clearer because it shows you the different associations that the bladder has that you that we were certainly tested on in the exam through ultrasound imaging. So here you can see this is a transverse view through the pelvis, um, looking at the bladder, and in a male patient you'll see the bladder, and then you will see the prostate directly posterior to the bladder. So that's the main association to be aware of really in men. It's a bit more complicated in females, and Bhavna's got some good kind of ultrasound images that will explain this a bit more. So I won't dwell on this, but this is a long section through the urinary bladder, and you can see kind of posterior to the urinary bladder the associations. So the uterus running kind of posteriorly here when you've got a well-filled bladder on ultrasound, and the vagina again running posteriorly and adjacent to the urinary bladder. So it's certainly worth being aware of how these associations look on ultrasound. So again, just an axial CT through the pelvis. And here we can see anteriorly, we can see the urinary bladder that, when collapsed, does form kind of a more kind of triangular shape, and we can just catch some of the prostate and seminal vesicles here. But Bhavna will go through that in her talk as well. And then kind of this sagittal view, I couldn't. This has got pathology on. There is some fluid within the peritoneum, but this kind of highlights the different areas of the bladder quite nicely. So you can see the bladder here, and then as we said, anteriorly you can see the apex of the bladder, and then running the ligament running from the bladder kind of superiorly, which Bhavna will discuss a bit further, is the median umbilical ligament. And then posteriorly and postero-inferiorly, you've got the fundus of the bladder, and then here you've got the body of the bladder, and this kind of superior part was considered the dome of the bladder. So not too much really to know from a bladder point of view, but we'll see some more MR images of that coming up. So the urethra. So I'll concentrate on the male urethra because it's the most important one to really know, because it's longer and is more complex, and it's split into a posterior and anterior section. So as we can see on this schematic diagram here, sorry, this one just below, you've got the posterior urethra, which is anywhere from the internal sphincter, the bladder neck, through to the external urethral sphincter, and this contains the prostatic urethra and the membranous urethra. Number 1, prostatic urethra. Number 2, membranous urethra. And then the section that's most characteristic, as you'll see on the studies that I'm going to show you next, is this bulbous urethra. So it's exactly what it says. It looks bulbous on fluoroscopic studies, and that then becomes the penile urethra, which is the longest portion and the final portion, which drains into the external urethral meatus. The examination that you're most likely to get tested on, from my point of view, I think, is a urethrogram. As we said before, this is a retrograde cystourethrogram. Retrograde because we've got a bladder catheter in an area called the fossa navicularis, which is a normal dilatation of the distal end of the urethra, penile urethra. And this is where the balloon sits that then instills contrast, opacifying the urethra along its course and filling the urinary bladder. So working down from the urinary bladder, in a male, we have the urinary bladder, and then the first segment is the prostatic urethra. Something that I did see in practice questions that I did last year was this area being arrowed, the verumontanum. So this is an area of the posterior urethral crest which on these studies produces a filling defect within the posterior part of the prostatic urethra. So that's something to be aware of. That is an area that doesn't fully opacify with contrast, and is an anatomical area that is useful for the urology surgeons when they're going ahead with kind of prostatic surgery. So the prostatic urethra then becomes the membranous urethra, which is this area that will appear kind of fully opacified. And then, as we mentioned before, the area that's gonna be the most kind of easy to recognize is the bulbous urethra, and you can see why it's called bulbous. You can see that it's kind of quite distended. And then this will run through, as we know, into the longest portion, which is the penile urethra. And then we've already spoke about the fossa navicularis here. Yeah, so we just included this slide again. So a sagittal cross section that shows how the the male genital system appears in kind of schematic view, and we can see the urinary bladder here, and we can see the prostate gland, and then we can see the urethra running through here down through the penis. But Bhavna will go through the prostate with you and go into a bit more detail about the ductus deferens, the vas deferens, and the ejaculatory ducts. So in the next talk. So finally, testes and epididymis. In terms of what you need to know, so the testes is supplied by testicular arteries that come just below the renal arteries on the abdominal aorta, paired structures that arise directly from the abdominal aorta. And then on this kind of schematic diagram, you can see the testes itself. The things really, I think, to keep in your mind is that the tunica albuginea is a kind of a fibrous tissue that lines the testes, and the tunica vaginalis is a serous layer, kind of a serous layer that is the most kind of lateralmost layer of the testes. So it's tunica vaginalis most laterally, and that's a serous layer, and then tunica albuginea, which is a more kind of fibrous layer that surrounds the testes. And then you get the kind of the tubes that then drain into the rete testes, which then drains into the head of the epididymis, and then epididymal head drains into the epididymal body, inferiorly into the epididymal tail, where it then becomes the vas deferens and runs up through the spermatic cord. So, yeah, epididymis, posterolateral to the testes, has three anatomic regions: head, body, and tail. And this is how it looks on. This is how it looks on ultrasound. So I've just shown the orientations here. So this is kind of a long section through the testes. Outermost layer is the tunica vaginalis. Innermost layer that you can see, which appears on this kind of image separately and quite echogenic, as the tunica albuginea. And then you've got the body of the testicle itself, which has got this kind of notable kind of speckled appearance. And then anteriorly, you've got the scrotal wall, and that is just a transverse section through there. And then finally, two other things to be aware of on ultrasound. So we can see the testes, we can see the superior pole of the testes here, and this area just separate to the testes is the epididymal head. This seemed to come up quite frequently in practice questions. And then finally, this area with the arrow that you can see, and you can kind of see it on this image as well, is called the mediastinum testes. And this is an echogenic structure that is actually a continuation of the tunica albuginea and kind of incompletely that divides the testes. So if you see a linear echogenic structure within the testes on ultrasound, then it's the mediastinus testis. Okay, so that's me finished for that section. Does anyone have any questions? Okay, that's great.
I think if you have a question, I think someone's got their hand up. If you could type it in the chat, then we can get round to answering it. I think there's a question now in the chat. Tim. Sorry, you've muted yourself, Tim.
No, it's so the verumontanum is a different structure to both of those. And in terms of the vas deferens, that's something that that Bhavna will go into in her part of the talk as well.
Yeah, and just to sort of add in the verumontanum, it's like Tim said, it's different, and it's also something that's sort of well seen through cystoscopy as like an eminence in the urethral lumen. So it's often used by urologists to as a landmark to identify the internal bladder, internal urethral sphincter when they're doing procedures like TURPs.
Okay, so I think we can have a 5-minute break now. Or maybe we can afford 7 minutes break and be back at 7. So at 7 p.m. sharp, we will restart the